Yeah, Dr. Goyal.
Yes, sir.
Yeah, please, you can go ahead with your talk. This is a talk on PTA with carbon dioxide angiography in non-healing ulcer. These are very important situations, and when we land up with nephropathy and we are totally restricted to use, ionic contrast or non-ionic contrast, we have to adapt to this technology. I actually find it very useful in our renal patients. And Dr. Kishore Goyal is one of our consultant cardiologists in the Apollo group of hospitals practicing in Ahmedabad. Dr. Goyal, please.
Sure. Thank you, sir. Thank you for the introduction. I think absolutely correctly told by you that in renal patients we need to use this technology, and I think I used it less frequently and landed up in problems, and rather after that started using this technology, and I found it useful rather than people telling that it's not easily visible. The visual clarity is not there. So later on, we have started using CO2 angiography quite frequently. So this case is not such not very interesting, but let's discuss something about CO2 angiography in this case. A 70-year-old male, diabetic, on maintenance hemodialysis, but still we used CO2 angiography in this patient. Presented with non-healing ulcer in the right heel region, and Doppler was suggestive of critical popliteal stenosis, along with tight stenosis in right posterior tibial and absent flow in anterior tibial as well. So this is the CO2 angiogram, the antegrade puncture, and you can see a tight stenosis in popliteal just before the trifurcation. This will be rather clear. Yes. So we first of all decided to routinely predilate the lesion with 4O balloon. This was a routine predilatation with the balloon, and after the routine predilatation, we decided to do sirolimus eluting. This is a sirolimus eluting balloon, 4/100, and we got quite a satisfactory result. And then we went into the posterior tibial, which was showing very tight stenosis in the distal, just before the ankle region, and the peroneal was also a bit. There was a stenosis in peroneal as well, and ATA was 100% occlusion. So we did the balloon dilatation of distal posterior tibial, as the lesion was mostly in the heel region. So we dilated with this is 2.5 balloon, normal balloon. We did it at two places. This is a 2.5 millimeter balloon, and after this we did the DCB here as well, a sirolimus eluting balloon. This was 3/35 millimeter. This is actually which we use in coronary as well. Indian made sirolimus eluting balloon, 3/35 millimeter balloon. So this here, the distal region, you can see the tight stenosis was there. So we did the ballooning over there as well. And then finally, this was a CO2 angiography image. Yeah. This is the final image of the posterior tibial. And in proximal also we checked it again in the popliteal. So the flow was good, and we just took one contrast image just to confirm our whether the flow is good or not. So it was done with sirolimus eluting balloon in right popliteal and posterior tibial. So CO2 angiography is good alternative to routine angiography, especially in renal patients. Because of its lack in renal toxicity, CO2 angiography is preferred in CKD patients or patients with allergy to contrast. However, the most important point in CO2 angiography is that it has to be done in DSA only, and with the side effect of pain sensation. A lot of pain sensation is there. Thank you. Thank you so much, sir.
Thank you very much, Dr. Goyal. And this is indeed a good tool, and it's very easy to use. We just need a proper valve, and CO2 is there in the hospital. The only thing where it cannot be used is if you're going supradiaphragmatic and arterial side, you cannot use, and you can use it on the venous side. And it has another issue that you have to give. It stays in the blood for some time, and it is a buoyant gas, so you have to manipulate the position of the patient to actually get good opacification. Sometimes raising a leg a little would actually give you a better opacification as compared to flat position. So let's move on. That was a very good presentation. Let's move on to the next talk by Dr. Tulio Navarro. He was here, and we also have his talk in the recorded mode. So Dr. Navarro.